Welcome back to the PainExam podcast. My name is Dave Rosenblum. I'm your host, and we are covering a great topic today, and that's complex regional pain syndrome. And we have the leaders of the RSDSA, the Reflex Sympathetic Dystrophy Syndrome Association, on the podcast today, and they are talking about how they are helping those who are suffering, as well as spreading awareness amongst patients as well as clinicians. In addition, I regretfully had to postpone my Ultrasound Live in Training course. I am doing the webinar December 6th. It's a comprehensive ultrasound course covering the upper extremity, lower extremity, peripheral nerves, soft tissue, as well as spine. It's 4 CME credits. You can log in at painexam.com/events. There's a link to register. And I also released the genicular nerve video, which I hope you have watched already. If not, please check it out on my YouTube channel or the PainExam website. I used a mid-frequency probe for this, an L7, and there is a higher frequency probe for the genicular nerves, which I used to cover for the course, in which you can actually see the nerves. Those are the still images, and you can note the difference in quality, but of course, the disadvantage to the high-frequency probe is the depth of penetration. But you can see great resolution on both probes, and I think you'll find the video quite useful and easy to implement into your pain practice, or anesthesia practice, physiatry practice, regenerative medicine practice, or whatever you're doing. Welcome you all back to the PainExam podcast, and today's a special treat. I have Beth and Jim of the CRPS or RSDSA, the Reflex Sympathetic Dystrophy Syndrome Association, and they reached out to me, and I think this was really a great thing that happened, because I didn't even know they existed, but this is something that has definitely been needed, because as you know, if you treat CRPS or if you have CRPS, this is a devastating illness that is often misunderstood by family members, friends, as well as doctors. And you get judged, and a lot of people's complaints get dismissed. This is a disease that they used to actually do amputations for. And there was a lot of crazy things going on. There are still a lot of crazy things going on with this disease. As I mentioned in one of the previous podcasts, I had a patient who wound up in a wheelchair because an IV pole fell on her finger, and the disease spread to her leg. So this is a real deal, and I want to thank you for coming on the show and say welcome.
Thank you.
Well, really excited about this opportunity.
Great. Well, if you don't mind, can you first tell us about RSDSA?
Beth, why don't I begin? So we're an organization that was started actually a long time ago in 1984 by two moms whose children developed CRPS. And just as people still today, they went from doctor to doctor to seek a diagnosis, and eventually they found a brilliant neurologist at Jefferson, Robert Schwartzman, and he convinced them to start an organization to build awareness, to raise money for research. And that was so long ago, and they have since retired. The Davises and the Thomases, and now the organization is based in Milford, and we have both national and international outreach.
Wow. And just curious, you said they're children, or they were young adults who were diagnosed with RSD?
There's actually been a case report of someone who's a child as young as 2.5 years old. And basically, the prognosis for children, if they get to a rehabilitation program, is quite good.
Right.
That's some great news, but it can affect children, teens, and adults, mostly female.
Right. Usually of reproductive age, and I've rarely seen a patient above 70 years old with the illness. And I often, sometimes encourage my patients who have RSD to say, usually sometimes it runs its course, and the patients, as they get older, sometimes they either learn to cope with it or live with it, or the symptoms sometimes do abate to some extent. And I've seen that happen. There's probably a good reason why you've never seen an 80-year-old with this, or I've never seen an 80-year-old with this, or a 90-year-old. Have you? You have. Wow.
Yeah.
Both of you.
We've talked to.
Please
patients.
Educate me.
Yeah, and in fact, I can speak of one reached out directly to Stacy because we co-chaired a walk on Long Island. I wish we would have known about you.
Yeah.
For 4 years, and one of from the PR that Stacy did, an elderly woman who was like 88 years old reached out to her and said, I've been living with this like alone, just isolated because no one believes me.
Awful.
So
Right.
I think too many people fall through the cracks, you know, and as you get older, you have other comorbidity. And so if you have like diabetes, a lot of people fall through the cracks because they say, well, you already have neuropathy. So,
right.
I think epidemiology shows that the cohort is really 50 to 70 is the largest incidence.
Mm-hmm. 50 to 70 years old, the incidence. Interesting. From my practice, I'd have to say I see it mainly in 30s and 40-year-olds. But that's anecdotal. And I do have a whole bunch of questions here. So the first question I wanted to ask you about is the history behind the CRPS Awareness Month and the Color the World Orange Day.
Beth, why don't you begin?
It's actually a huge empowerment for patients and even practitioners who treat CRPS to have the whole month where we try to bring education such as this, speaking with you, where young people, they've done things in their schools. I mean, it's difficult with the pandemic now, but you try to teach in different forums. The Color the Word Orange Day started, I think it was 6 or 7 years ago, and it's the first Monday of November every year. And every year that it's occurred, more and more large buildings and very accessible places are colored orange. And it's really, for me, it's wonderful. They had a huge sign in the city with a ribbon of CRPS awareness. That's the goal of the month and the day.
In New York City or a different city?
Yeah, New York City, but it's throughout it's not just in America, it's also globally. You find all these bridges and municipalities that are lit in orange. It's really a very universal global thing to do.
Well, that's amazing.
Bridges up in New Zealand and Australia. I think what we're trying to do is CRPS is a rare disease. There's 7,000 rare diseases out there, and 1 in 10 Americans are affected them. So we're really trying to raise our visibility because, as I said before, even now, the individuals with CRPS are seeking a diagnosis and going from health practitioner to another one. It's really
That's right.
Increased visibility.
That's right. I currently have a patient who approached me and had some altercation with a relative where the relative grabbed her wrist, and she had some pain syndrome in her hand, and I did not diagnose her with CRPS because I honestly don't think she has it. She had none of the criteria that really fit it. It just didn't sound right. But she is perseverating on this idea that she has CRPS. So she's been all over the place, neurologist. And I know that the frustration that these patients have going from place to place for the diagnosis, but she actually wanted that diagnosis, and I actually couldn't justify giving it to her. But there's a lot that gets carried with that diagnosis. And I don't know if you wanted to elaborate on that in terms of how your patients are diagnosed, or the Budapest criteria, or even just how they present, or even make it their way to your organization.
Well, I can touch on that one a little bit.
First of all, Beth, I'm sorry. Beth is a nurse and Jim is a social worker. I just want to give you guys, did you want to just talk a little bit about your history as to, how you came about being part of this organization before we begin with that?
I'll begin. I was lucky enough to be on the National Board of Rare Disorders, and in CRPS, the RSDSA was looking for a professional director after the founders retired, and I was lucky enough to interview and be hired. Now it's 20 years ago, and it's been just an honor and privilege to really grow this organization to help people. That it's an invisible illness. So often people are having great difficulty, and that a lot of people get better, but we see at CRPS, we see people who are newly diagnosed, and we see others who have been struggling sometimes for decades. And as Beth, it can go into the 70s and 80s. Wow. It really, for most people, it doesn't burn out.
Look, I've been treating this for 14 years, but you guys have definitely seen more people with it than me. Because CRPS is a minority of my practice. and it's usually a minority of most pain practices, but it's out there, and pretty much every practice does have them. How about you, Beth?
Well, for myself, I was, practicing nursing in a hospital, and I had a slip and fall and tore my ACL, and that surgery set off my CRPS. But it took 6 months, and that's fairly not a lot of time to be diagnosed with CRPS. And I was elated because at least there was a diagnosis, because I was just scanned and had all these diagnostics to rule things out, which is usually how it goes. Until I finally clearly got the diagnosis. And it's just by luck that I reached out to actually Jim. Oh. And he spoke to me, and I was in tears for 40 minutes, because when you first start researching it yourself, it's really not a great condition to be solo reading. It's, sure. With the suicidal ideations, and, you're thinking, good grief, what am I supposed to do now? And unfortunately, back then, I got the diagnosis. That was it. They were like, well, we don't really know what to do with it. And so that's how I started with the organization. They helped me. And as I empowered myself and got into a better regimen, I'm able to now give back.
Are you, if you don't mind, I'd like to just explore your regimen. Can you let us know what you've tried, what works for you, what doesn't work for you?
Sure. I'm definitely better managed than I was before. The biggest frustration is when you first start. You're also learning yourself, because as a nurse, I had never heard of this condition before, and I was a ICU trauma nurse. We tried all like the anti-seizures, which I didn't tolerate on any level. Mm-hmm. And interesting enough, Jim knows his story. The first time I went to a pain management doctor, I got 9 scripts at once. And I said, well, what do you want me to try first? And they said, just all of them. And I said, listen, I'm not doing that.
This must have been prior to 2010, I would imagine.
Yes. And, I said, I can't, reliably tell you what's working or what's not working, so we're not doing that. But had I not been a nurse, I probably would have said, I just need to get rid of it. Fine, let's start them all. Antidepressants. I tried a whole slew of things. Mainly none of them worked. The ones that did work for me, thankfully, and it took time. It took time, which is difficult to have time when you're in this physical torture. Sure. Savella is very good for neuropathic pain. It is an antidepressant, but it was good for me. Right. Low dose naltrexone has been very helpful for me. That. However, that took me about a year before I could get on a maintenance dose, because the capsules, for some reason, no matter what the dose was, I couldn't tolerate it. So I went to suspension, and I can't do it all at once, so I do it BID dosing, just 1 milligram BID, which is very, very low, but for me, it gave me some really good results. Nucynta has been very helpful. It's a new opioid, and that's for neuropathic pain. So, the other meds that you start off on when you're in pain, the Oxy and the Vicodin, it does nothing. It just slogs you in the head.
That's right.
But it doesn't do anything. The Nucynta did help me while I was trying to get on a better regime. And I'm on a ton of other things, tons of other things.
Have you been through any interventional pain management procedures?
Yep, I did years ago. We did do the sympathetic blocks. And the only thing that did for me is it turned my cold, dead foot into warm and hot. It switched it for me, actually.
Temporarily or for the long term?
No, for the long term. Wow. So now I can actually be cold and hot at the same time. I have a whole lot of skills.
Wow.
I mean, it's not funny, but you have to laugh on it on some level. And the other thing that really helped is I started ketamine infusions a year and a half ago. And depending on who does those infusions, because everyone seems to do them a little bit differently, I went to an excellent physician who I like his protocol. And after I did the introductory sessions, and then I went back 2 weeks later for the high dose bolus, I could totally feel the switch. I had a 50% reduction in pain. And beyond that, I felt clearer in my head. Many people with CRPS have that brain fog, and you can't concentrate because you're in this constant state, of central sensitization, just going. But I really could feel it switch after the ketamine infusions.
Did your insurance cover those infusions?
Of course not.
Yeah.
Of course not. Part of the problem, even when you get insurance coverage, because really they don't have to cover anything because there's nothing that's FDA approved
Right.
for us, unfortunately. Like for work comp, for example, they might approve like 6 sessions for you. And that's great and you're excited at the beginning, but then as you're getting close to 6 and you put in another request as a practitioner saying, well, they need once a month now, we need to do it.
Right.
Now you have to wait and go see an IME. So that delay in time now eradicated everything.
So you were workers' comp, that's right. That's tough.
Well, that's a whole separate podcast.
Yeah, that is, oh boy. Yeah, because I'm actually struggling. I have patients who are neglected. They're not being treated. I can't treat them. And that's why I take workman's comp, but I don't take a lot of it, and I really don't like it. It's just a very difficult position that puts the patient in as well as the physician. And you say, this is what you need, this is what I think is best for you, and then you can't do it.
Yeah.
Have you ever tried neuromodulation?
That is something for me that I choose not to do. That's my last total ditch effort. And I'm better now, so I don't need to do that. I really don't want any more invasive things done to me. I've already had spread. I have full body CRPS. It's in my left eye. It's in my GI system. So I really choose not to do anything that's invasive like that.
Understood. Are you aware of peripheral neuromodulation?
Mm-hmm.
Okay.
Yeah.
Because there are some units that are very, they're minimally invasive, meaning there's no batteries implanted, there's no incision.
Mm-hmm.
The needle stick with a wire sticking out, or maybe tunnel, depending on which company you're using. But I know some people are doing that for CRPS.
Mm-hmm. Yeah, we have our walks. I'm sorry, Jim. We've had a lot of all the neuromodulation companies come to when we've had walks to really explain to patients and practitioners
Right.
what is available. It's just something I've chosen not to do.
Right, I understand.
Have you found that effective for CRPS type 2?
I'll tell you what, I started doing peripheral neuromodulation. I'd say spinal cord stimulation, I've had good results with for CRPS, but I haven't done it particularly. The CRPS patients I have, they're kind of, I'd say they're kind of, most of them are long-term patients. I haven't had any new recent ones since I started doing the peripheral neuromodulation. And the problem with the long-term ones are, the CRPS is older, so they might be a little more refractory to treatment. However, I'm very honest, maybe a little too honest with my patients. And if you listen to my podcast, you know my feelings about cervical and thoracic epidurals. So when I tell people about the thoracic and cervical epidural for a spinal cord stimulator, they often get scared because you're so close to the spinal cord at these levels, because it is more invasive or riskier than doing some sort of lumbar epidural, for instance. So I'm very honest about that. And with the peripheral neuromodulation, I have yet to do it for CRPS. My partner did, and he had very good results. Very good results. And I'm sure for a lot of people it will work. I don't think it will work for everyone. But as I've been saying lately, the two biggest upgrades to my pain practice in the last few years, things I've really seen make a difference and work, have been the peripheral neuromodulation for almost any pain problem. Not every pain problem, for many pain problems. I mean, anything from OA, shoulder, knee, hip, post-surgical pain, to even spine issues. And I have had, actually, I don't know if you'd call it CRPS. I have a patient I just did a peroneal nerve stimulator on who's doing very well. She was seeing another pain doctor who was just giving her medication, and this other doctor didn't know how to do ultrasound guided injections. So for years she was asking for a shot there, and this doctor was saying, "What do you want me to inject? There's nothing to inject." Meanwhile, the first time I saw her, I took an ultrasound. I looked at the peroneal nerve, and my ultrasound image went along with the MRI report saying that the nerve looked tethered and it was damaged. And I still wouldn't call her CRPS because, I mean, she's probably a causalgia, I guess, so maybe you could call it that. But she didn't have all the other classic symptoms of allodynia and this or that. It was just really painful in the peroneal nerve distribution. And she did amazing. And we just implanted the peripheral stem, and she's doing very well. So, I teach ultrasound-guided pain procedures, and I'm always advocating that the doctors who don't know how to do ultrasound learn it, not only because I'm one of the instructors, but because it's really helps you, it gives you that flexibility. to do almost anything you can to treat the pain. You find the nerve, wherever nerve it is, because not every nerve can be found with an X-ray machine, and you try to treat it, whether it's PRP or local anesthetic or neuromodulation.
That's great.
So
It's always been offered to me. Let me just say, it's always been offered to me. My philosophy just was I have to try all medical stuff first to see where I can get, and then I would choose to do that. That was just my personal preference.
right, that makes sense. I mean, so just so you know, my podcast was mainly intended for doctors, especially pain doctors. However, all sorts of doctors listen to it, and now I'm learning a lot of different patients listen to this podcast. So, first of all, if there's something you would say to the pain doctors across the world, because it's not just America, we have about 85% of the people listening to this are in the States, but the rest of them are scattered all over the world. Is there something that you would maybe say about your organization, and there's a way maybe that you can reach out to them or help them or guide them or serve as a resource? Is there?
Sure. I'd like to say that we've developed with both pediatric and adult courses for CRPS for doctors and nurses, and they're on our website, and they're free and they're accredited and they're wonderful. There's a great young pain specialist, Jay Josie, who used to work for the World Health Organization, and he has done it, and it's really fine. The other thing I think that doctors have to do is plant that seed of hope, that people have gone to so many doctors before they see you, and basically they're downcast and they don't have much positive optimism, and I think you really have to help them to see that we're going to try together to help you deal with this unrelenting, persistent pain.
Right.
And they also have, you've been doing those because of the pandemic, a lot more the Facebook Live with physicians and other specialities too. So anywhere in the world, which it's great for patients, because at the beginning, I did go to a CRPS conference. RSDSA had hosted a conference, and I went to. It was great. It was a combination of practitioners like yourself and patients, and we all came together, and that's wonderful. But I was bedridden for a long time, so I couldn't go to those. So having the Facebook sessions has been really overwhelmingly taken, right, Jim? You have had a lot of people that have come.
When we used to do our regional conferences in Houston or somewhere, we get 145 people. We had Stephen Brule, who is a wonderful researcher, psychologist, talk about the science and mystery of CRPS. And we had 1,100 people live, and since then, thousands of people have seen it.
That's great. That sounds interesting. I'd love to be there. And
all over the world. It's been great to unify our community and give hope.
And who would have thought you're located right here in Long Island?
Well,
right. Yeah. I looked at the address in the email. Like, no, it's my partner lives there, so it's a very small world, I guess. But with CRPS, I've had patients who have gotten from the worst place in the world to functioning and actually happy, I guess, which is a big deal because a lot of them are not happy when they have CRPS. I mean, who would be? That nurse with the IV pole that fell on her hand, she wound up getting spinal cord stimulators in her neck and in her lower back, and she was able to walk after that. She went back to school and wound up getting married. So that's great. I have another patient who wound up getting a spinal cord stimulator from a previous pain doctor, and she actually transferred care to me. So she was doing very well. So I'm going to give that doctor the credit. But she was a CRPS patient who went on to get married and get pregnant, have a kid. And with her, she would come to me every 2-3 years for a small little nerve block in her leg. And that kept her at bay. I mean, I'm working on the shoulders of the previous pain doctor who did some fine work with her, I think. So I use these examples to tell the patients who are in really dark places that there is hope. The biggest problem I find with a couple of my patients when I think about it is either they're in a tough spot because they're workman's comp, or maybe their insurance, or I have one patient who comes from New Jersey, and unfortunately, she met me before her psychiatrist was treating her with high-dose opiates. I mean, this is back in the early 2000s when that sort of thing went on unchecked. Now, I can't imagine any psychiatrist using high-dose opiates on a patient if he's not a pain specialist. But he was doing that, and I looked at her case. I'm like, he didn't even bother sending her to a pain specialist. And she was defected, but she also had a history of drug abuse when she was younger.
Wow.
So it's like kind of like, those patients, I think, definitely have a poor predictive factor in their outcome. But
I think one of the issues is that pain in medicine is still looked at as a symptom. It's not looked at as a disease.
Right.
And if pain was looked at as a disease, we might even have an NIH center that would be able to bring in CRPS and all these chronic, complex, painful conditions. It's really not about the pain. A lot of times patients will say, like I've even said, this isn't painful. This is physical torture. I've had endometriosis and lots of surgeries. Those are painful. That's not what this is at all.
Right. Yeah.
Jim, one of the other things you should share too is RSDSA. I'm sorry, the landscapers just arrived. I apologize.
Okay,
RSDSA is part of research projects. We've been sponsoring and co-sponsoring lots of research projects that would be really helpful for practitioners to know.
I think, thanks Beth for that little hint. Basically, over the years, we've done about $2 million worth of research. And right now, what we're really focusing on, because CRPS is not a homogeneous disease, and I think clinical trials have failed because they try to put everyone in one bucket. And so what we're working at, we have a study at Stanford, and we have another study in Switzerland. We're trying to look for biomarkers in the skin, and also we're trying to look at the autoimmunity and also the autoantibodies that are attacking some of the immune systems of people with CRPS. And the other thing that we're really looking at is that, as Beth mentioned, the ketamine, we're looking at nitrous oxide at the Cleveland Clinic to see if that might provide some relief, also lead to some opiate sparing, get them off opiates, and that might be something. And I look at it that it might also be something in the emergency department when someone goes and they want relief and people are seeing them as a drug seeker rather than someone needing care. So we're excited about some of this research, but no breakthroughs yet. But
yeah, I think you touched on something very important with pain management and research. And I'm not the guru of research by any means. It's a very heterogeneous group. And on top of that, when you're assessing someone's pain score, people's levels of rating their own pain vary so much. 9 for one person is not a 9 for another person. And then if they're upset about maybe a financial issue or their spouse or their kid, that could increase the pain score. So there are so many confounding variables. I'm not saying to invalidate pain management research. I'm just saying that there's a lot of I guess, errors or biases that can occur because of this.
Again, because pain is looked at as a symptom and not a disease.
That's right.
That's a huge issue. And it also depends, like I would always try to make my doctor appointments early in the morning, because as the afternoon went on and that witchy hour in the evening, the neuropathy got so much worse, especially that's why nobody sleeps at night, because it got so much worse. So by the time, if I had a doctor appointment in the afternoon, I couldn't even speak, nevertheless explain in my 10 minutes what's happening and what's not working.
Right. And that's the patient's point of view. I'll tell you the doctor's point of view. That doctor has been talking to 40 pain patients or 30 pain patients. So his patients, the other, right, exactly. Because sometimes when people are really suffering and you're there for them, and if you're really, it's also hard on the clinician to sometimes hear their stories, because it's really moving and it's really depressing, and it could take a toll on everyone involved.
Well, as a support to practitioners, RSDSA has lots of things that can work both ways. So, for example, I've given my local pain management and my other pain management doctor does my ketamine infusions. I made like a box, and in it, what I put is a card that RSDSA has, and I've carried it with me all the whole time, because believe it or not, there's been issues when I've had CRPS crisis that I cannot speak in the ER. So my husband knows. He takes this out and shows them.
Wow,
And honestly, it's validating to me as the patient, but it's also as a former ER nurse. I don't know every disease. When someone came in with something that I wasn't privy to, they handed me something. I went, okay, I got a brief little outline of what's happening. So every practitioner who has pain patients should have this. The other thing that they have that you can even have in your office, it's all downloadable. It's from RSDSA. These are dental guidelines. So most people don't want to go to the dentist to begin with.
I need that. Actually, I'm dealing with 2 patients right now with that exact issue, so I do need that.
And unfortunately, oral health is the gateway to our regular health. And most people would rather lose their teeth than do it. So one side is for the patient and one side is for the practitioner, but yet you're both learning from each side. The other one is, this one is the emergency guidelines. So unfortunately, I've been in the ER quite a few times, and they do look at you like, what's wrong with this one, you know? But again, one side's for patients, one side's for practitioner. So, and the other one is a hospital. And I used to have them, before everything was electronic, tape it to the chart so everybody would know what I have. Because otherwise, you just, listen, I've been a practitioner, I know. You just look like one of those crazy patients saying, oh, I have this pain condition, and people go, oh, it's one of those people.
That's right. And not everyone, but many clinicians, nurses, doctors, they will just label you as drug seeking or crazy. And I've seen it. And
How horrible is that?
I've seen colleagues come up to me, and I'm not mentioning names, and say, oh, you take care of that poor girl? Isn't she nuts? And I mean, I had a patient would wear socks on her hands because she couldn't touch anything from the RSD. Imagine if someone's listening to this and doesn't really know about RSD or CRPS. Every drop of water when you take a shower is like a nail coming into your skin. And that's what these patients experience every day. And sometimes they need people to open the doorknob for them, to do things for them. And it's, and then you get labeled. And
how about a patient, like if I came to your office, right, and I'm all in your exam room waiting, I'd be the one without the lights on. I'd be sitting in the dark. And then people go, well, no, we'll put it on. Don't put the lights on for me. Because to me, I feel like I'm at the beach and I'm having a sunburn. Leave the lights off.
That's right.
Most practitioners would say, oh, she's a little screwy. The other thing I just want to put in quickly before we forget is that we recently did little cards. So for example, when I was in the ER and you have like protocols that you have to retain really quickly, you can put it on your ID badge, and it talks about what CRPS and suspect in patients with disproportionate allodynia and hyperalgesia. And the back of it has the Budapest criteria, which again, for even if you're just a beginning practitioner to learn about CRPS, I would be thrilled if I saw someone having this, because I'd say, oh God, at least they've heard of it. That's step one, you know? So this is something that would be very helpful for practitioners.
That's right, because in the ER or some offices, the person evaluating you, aside from the nurse, could be a med student, resident, or even, I mean, most ER attendings I would think know about RSD or CRPS by now, but maybe they don't.
You'd be really surprised. You'd be really surprised. And even if they do, you know, that's only step one to really understand the whole comprehension. For example, my ICU stay post an injury, when I fell through the deck, I didn't have any fractures or lacerations. I was just banged up, but I wound up in ICU for a week on IV ketamine. And I developed pneumonia within 12 hours. If they had done in the ER, recognizing I was having a CRPS crisis, if they would have done 4 hours of ketamine infusion somewhere for 4 hours, I could have went home.
Right. I always had this concept of a pain management emergency room. Not a place to get opiates, but a place to either get, let's say, ketamine or other painkillers that are not addictive, or get an injection.
It's a real issue if your patient has the condition and they just sprain their ankle, and now it is just proliferated into this thing, and you're at the ER because your pain management doctor's off on a weekend or whatever, and they look at you and they go, it's a sprained ankle. We're not going to give you anything. But if you understood CRPS, it's disproportionate hyperalgesia and disproportionate allodynia. It's not what you just learn in medical school that it's allodynia. It's disproportionate.
That's right.
That's the key, if we could get through in the ER with that.
That's right. And that's why a lot of these patients need so much support. And their family needs to be educated, because their family will judge them. Their family will get sick of doing things for them, and they're not going to understand. I'm sure there's a lot of divorces and marital stress and strain over this. So it's really good for if you have a relative suffering from CRPS or telling you about it to understand that, because of the patients do need the support system. It's a real disease. It's a bad one too.
It is a real disease. And another thing ERs should learn is you don't put ice on your CRPS limb, because it actually makes it worse. And that's counterproductive to when you come in and you fell and you have swelling, the first thing you do is put ice on it.
Right, exactly.
I'd like to just stress also too about the interdisciplinary care of CRPS. Too often people are just given one intervention or one medicine, and really if physicians could work in that team of physical and occupational therapy, psychologists to help with the grieving of the loss of their previous life, and also maybe a vocational counselor, because if you're getting better, how do you go back into the workforce? And that's the goal.
Sure. CRPS has a pretty poor predictive value for return to the workforce, so it's very difficult. Yeah. But when I see it and hear it, it's always notable because of the challenges. So I am going to have to wrap this up soon because I have patients coming to the office. But before I do that, first of all, I wanted to say what you guys are doing is fantastic. I wish I knew you guys existed. I'm very happy that you guys reached out to me. And I do hope that in the future we could help each other, help the patients, and just spread your message, which I think is really good, because you're right. It's not just an intervention or a pill. It's a teamwork approach. It's multidisciplinary. You need therapists, physical, psychological, you name it, OT as well. And there are certain things that I think, it's like having a disability where, when somebody's in a wheelchair, that you need to change the house, make a ramp instead of steps. Things need to be adjusted for these patients because it is a disability.
Exactly. And RSDSA is very supportive on a lot of different levels. So for example, we have the Brad Jenkins Patient Assistance Fund, and it was funded by a family member who lost their son to CRPS from a motorcycle accident, from an accidental overdose. So we give a small grant, and so it's funded people from being losing their electric power because they can't afford to pay for their electrical, or to see a CRPS specialist, or, so that is available. So for you as a practitioner, that'd be good for you to know.
Sure.
So if it is need-based, that would be a wonderful thing. And we also have the peer-to-peer mentoring. So if there's a patient who wants to speak, whether they're just, at the beginning stages of CRPS or they've been long in it, a lot of people have never ever spoken to someone. And yet on Long Island, we have at least 3,000 people with CRPS.
Wow.
Just last night we put together a networking session of 40 individuals who could just talk to someone else for 5 minutes. And it's almost like speed dating, and then go to someone else. And we linked up two people in Colorado, didn't know each other, 12 miles away from each other.
Wow.
One of those people had CRPS for 25 years and hadn't met another person. Bingo.
Wow.
It was like a God wink. It was so wonderful.
From personal experience, I've seen early cases of CRPS that have responded to maybe a stellate ganglion block, and then it actually resolves and it's over. And it's rare that you see that, because by the time people make it to me, they've had it for a significant number of months or years. And I think really teaching other physicians, physical therapists, et cetera, about the disease. And then they're learning. I get referrals from orthopedics right away now when they think it's been too long, the healing process, the orthos are getting better, but maybe the internists or other specialists need to be, maybe general surgeons need to be more aware of it. And it doesn't have to be just the arm or the leg. It could be in multiple places.
Yes. And actually, Jim and I did a presentation. We go around Long Island and different areas and do presentations. We did it in a Hofstra Medical School. and try to get in early, because obviously medical students and nursing students get like 4 to 7 hours of just general pain management.
Right.
Forget, anything special. So you're really, the competency and the practice gaps are huge. But one of the students actually said that one of their boards actually had a question on CRPS. I know it was one, but I was like, oh, right, that's great.
Yeah. Yeah. I get med students who don't know what it is. I still, even some residents, they're like, nah, the patient's crazy. I'm like, no, they have a real disease. This is something real. But that being said, I think this is amazing, and I'm happy for the introduction, because I do, since I'm a neighbor, I would love to be involved with your organization. I really think you're doing great.
Excellent.
And I'm going to post a link to your website on the show notes. Mm-hmm. And if you want to just say the website so anyone listening could come check you out.
It's www.rsds.org.
RSDS.
RSDS.org.
Okay.
That's great. And is there anything in closing you'd like to say to the audience?
Welcome to a world, practitioner or patient, of camaraderie. We're here to support you as well as you're going to support us. So when patients call, we can send you someone. For example, we have like dentists that are privy with CRPS. That's been huge. We're definitely looking for more areas to do ketamine infusions. That would be very helpful. That every practitioner should have in their office at least a copy of where you can send your patients to download all this information.
That's fantastic.
Yeah.
That's great.
Right? Is that good, Jim?
I think it's wonderful, and I want to thank you. We're so excited. I mean, because I always say that it's so disappointing that the normal physician might get 9 hours of pain management training, where the average veterinarian gets 75 hours. So,
ridiculous.
Wow, I didn't know that.
Yeah, it's amazing.
Wow.
Because vets recognize it as a medical condition.
Right.
Not just a symptom. And we're still looking at it as a symptom.
Wow. That's true. The whole thing of pain is the vital sign. Well, the pro side is, okay, yes, measure their pain. The downside was the whole opiate crisis, because that's what got into a little trouble. So that being said, it is a disease, and it does need to be treated as such with the respect that a real legitimate disease has. Thank you for coming on the show, and I look forward to seeing you and working with you in the future. And to all those patients out there, the website once again is rsdsa.org.
It's just rsds.org.
rsds.org. There we go. Thank you.
Thank you.